So going to bring it home. There's a lot happening in lung cancer. And so Sarah and the team and I, we decided to really focus on the most impactful. So I'm going to start out with talking about small cell and really practice changing studies there, and switch to non-small cell and talk about HER2 mutant patients. EGFR and locally advanced can be covered by our panel. And then I just want to mention an interesting timing of treatment slide. Okay, so right now for small cell, we are in the current era of immunotherapy, and that started with the Empower 133 and Caspian trials back in 2018 that added IO to frontline treatment. I'm going to focus on the IMforte and the Delphi 304 trials. This is the Caspian trial that actually showed that our patients actually at 3 years with extensive stage, some about 20% are still living. And so the Empower 133 also showed that with the addition of atezo, Caspian was with durva. Benefit was about 3 months, so from 10 to 13 months median overall survival. That's great, and that has changed since I have trained, but how can we extend that benefit to more people? Well, let's try to use our active agents earlier. So this is the IMforte trial that took patients who had gone through the induction chemo and atezo therapy 4 cycles, and then randomized them to either atezo alone or atezo with lurbinectedin, which is a cytotoxic chemotherapy. Now, a couple of things to note here. Patients with brain mets were not included in this trial, and that's important for our small cell population. We have at least about a quarter of our patients with brain mets. The other thing is that if you look at the patients who start, there's about over 600, and about a quarter of them, there's about 25% attrition to the point of randomization. So in other words, about a quarter of the patients either progressed on treatment or didn't have the PS 0 to 1 required to be randomized to the maintenance treatment. Okay, so here's the money slide, and this is the overall survival benefit of 3 months in the Lurbi atezo arm. This is a positive trial. This will change our standard of care. It's already been included in the NCCN guidelines and will likely be approved by the FDA, in my opinion. And that benefit, just remember, this is overall survival from randomization into the maintenance phase is now 13 months. Okay, keep that in mind. Later on, I'm going to talk about something else. Now, more intensive maintenance therapy means more adverse events. And so, in fact, you can't read this, but more patients had, I'm just going to skip over this in terms of time, but more patients had to either have dose reduction or dose delays, but only about 6% in the Lurbi atezo arm actually stopped therapy compared to chemo was 3%. So I think that for that select patient population, fit patients, no brain mets who've responded to frontline therapy, this will be the standard of care, certainly something that I'm talking to my patients about. But the question in my mind is really, are we just moving up that cytotoxic second line therapy? And I think the downside for patients is that they lose that window to recover from their frontline therapy. And so we don't know if they would do as well if you just wait a little bit longer. So I think the maintenance approach is very attractive. I'm going to talk a little bit later about Tarlatamab and other maintenance approaches. So the landscape for relapsed small cell really changed in 2023 or 2024 when Tarlatamab was approved. That's a bispecific DLL3 T-cell engager. And prior to that, we really had limited tools, and so Platinum Rechallenge was a really important tool. After Tarlatamab was approved, we now have that. We have lurbinectedin. The ADCs, I'm not going to go into, but they look really good. These ADCs are showing basically 60 to 80% response rates in the second line of treatment. And we were even talking about moving that up into the first line, so getting rid of the platinum doublet. Could you ever even think about that? That blows in my mind. So. The Delphi 301 was the trial last year presented at ASCO that led to FDA approval. The response rate was 40%. In the patients who got 10 milligrams, an additional 30% had stable disease. And the duration of response was somewhere around 9 to 10 months. So really a big breakthrough for our patients, and this was approved by the FDA. All those patients were actually third line and above, but it was approved for second line, right? So, wow, well, that's why everybody took a nice sigh of relief when the phase 3 trial for second line came out, that this ASCO Delphi 304, Tarlatamab versus chemotherapy investigator choice. About 40 of those 500 patients actually had lurbinectedin here. Primary endpoint survival, and that's shown in the next slide. So here, the benefit is, or the hazard ratio is about 0.6, and a 5-month benefit in median overall survival. This solidly puts Tarlatamab as a standard of care second-line therapy. This is just to show you that they included those really hard to treat patients, such as brain mets, and also patients who relapsed on, who are platinum resistant or refractory, and those patients also benefited. The overall response rate, 35%, very similar to the prior smaller trial, and the duration of response, almost 7 months. Pretty well tolerated. The main things that we worry about are the cytokine release syndrome, which happens in over 50% of the patients, mostly grade 1 to grade 2, but we do admit our patients for observation after the first 2 doses. Those are 2 weeks apart. This trial, actually Delphi 304, included patients with an outpatient monitoring cohort, and those patients did fine, and we're actually demoing kicking off our pilot outpatient monitoring. Right now, we still, for most of our patients, do admit those patients. If you want to send those patients to me, I'll get them treated first 2 doses, and then they go back to you. The ICANS, which is immune cell associated neurotoxicity, really around 1 to 2%, something that you need to watch out for, but certainly seems to be pretty manageable. So this is now second-line therapy. What about maintenance for Tarla? Now, this is from World Lung 2 weeks ago, and this is an early look at, it's an interim analysis on Dr. Paulson's trial, a small 88-person trial that gave Tarla with Ateza or Durva, and the median overall survival, again, time of randomization is 25 months. So compare that to the 13 months that we saw for lurbinectedin. Stay tuned for this. The phase 3 is ongoing right now, and we're participating. Just to mention this is another trial in the maintenance setting. This is a SWOG cooperative group trial that I'm national co-chair on, and this is called PRISM S2409, and we are going to take over 800 patients with small cell during their induction training, induction chemo and IO, subtype them to figure out which of their transcriptomic subtype they are and what their Schlafen 11 status is, and then randomize them to the targeted treatment plus IO versus IO alone. So this is going to be the biggest trial to integrate precision medicine around the subtypes that people are very excited about into practice. So stay tuned for that, and hopefully tissue will no longer be the issue for small cell. So the bottom line here is that small cell is not just a black and white cookie, one size fits all, extensive versus limited, everybody gets the platinum doublet. I think we're learning a lot more about the biology to see that there are a lot of different kind of cookies here, and hopefully we can target therapy. Certainly immunotherapy and Tarlatamab will be part of that. We're going to take a page out from the non-small cell. This is my switch to targeted therapy in non-small cell. Back in 2012, EGFR was the only oncogene that we tested for, and now in 2025, we test for 10, 11 if you include the EGFR exon 20 insertions. So, and they all have targeted treatment. So this really has changed a lot. I'm just going to focus in on the HER2 mutant population, and this is about 2 to 4% non-small cell. Most commonly, it's the exon 20 insertion mutation in the tyrosine kinase domain, but you can have point mutations, you can hit other domains. Trastuzumab deruxtecan has been the only HER2 therapy available for these patients in the past, but cevavertinib is a TKI that targets both EGFR and HER2 exon 20 mutations with activity, and zongertinib was just approved by the FDA. I'm going to talk briefly about those two. So this is the cevavertinib trial, SOHO-1 from ASCO. This included 2 cohorts. Basically, on the left were patients who had been pretreated pretreated HER2 mutant non-small cell, and then on the right, they had not had any therapy. They were naive to systemic treatment. In both of the cohorts, you see about the same results, it's about 60% overall response and disease control rate of above 80%. So very active. What about the safety and tolerability? Well, it's consistent with the profile. So basically about 24 of the patients had grade 3 treatment-related diarrhea on the blue side, so the pretreated population. The never treated population only had 1 patient who had grade 3 diarrhea, and there were no cases of ILD or pneumonitis. So very active, but has some toxicity. What about zongertinib? This is a phase 2 trial. This is John Hayman's paper in New England Journal. Two cohorts here. It's the HER2 TKI ADC naive, so they'd been 75 patients previously treated with platinum-based chemo, but no HER2 targeted therapy. Overall response rate 70%, duration of response over a year, and median PFS over a year. Grade 3 or higher drug-related AE 17%, and then in the post-HER2 ADC cohort, that's 31 patients who had been previously treated with both platinum and a HER2 targeted ADC, still had an overall response rate of about 50%. So on the basis of this, here's the swimmer's plot. That arrow is just to note that patients with brain mets were included and did have activity. Zongertinib was granted FDA approval last month in HER2 TKD mutation patients treated with previous systemic therapy. Okay, one last trial I just thought I'd throw out there. It's, I think, very interesting, 210 patients, phase 3 randomized trial. So the blue curve on the top is the early curve. So these are patients who were treated with their IO chemo before 3 o'clock in the afternoon, okay? And then the other curve is patients who are treated after 3 o'clock. So look at the difference in PFS. It's 11.3 months versus 5.7 months, hazard ratio of 0.42. How could that be? There is some thought about circadian rhythms, and in the lower left-hand corner, there's the circulating T cells. So the blue line is in the first panel is CD8 cells, our effector cells, and that's much higher in the earlier cohort, and the CD4s are much lower. So I just thought that was interesting to throw that out there. For non-small cell, the key points, look, understand the biology has led to a lot more effective and targeted treatments. We're testing for 11 oncogenes for diagnosis, and we have a new treatment available to target HER2 mutations, and then stay tuned for the EGFR and locally advanced updates in the panel. Thank you so much.
Thank you, Anne. It's a fantastic overview. So I would now like to call up our panelists. We have Tom Hayman, who is joining us from radiation oncology, and then 2 medical oncologists, Yeon Kim and Michael Grant. I think I see them there. So as they're coming up, if anybody has any questions for Anne now that she sat down. Okay. Save them for after, yes. Okay. So like I mentioned before, we have 2 cases. We will go through them fairly briefly because I know it's the end of the day, and those of you who have been here since the morning, I'm sure it's a long day. So we will take you through this first case, and then hopefully if we have time, we'll do the second one. We'd like to, though. So first, we are going to hear from Dr. Grant, who's going to tell us about his patient. So go ahead, tell us about the case, and then I'll ask you guys some questions as we go along.
So this is case one. This is patient who's 70-year-old female, has type 2 diabetes, came into the emergency department with complaints of subacute to chronic back pain, weight loss, shortness of breath, weakness. Other history is that she has no smoking history, only secondhand exposure. And the imaging that was obtained in the ED was consistent with a metastatic solid tumor, it looked like. And you can see on the PET scan that intrathoracic adenopathy, there was innumerable pulmonary nodules and lytic bone lesions. So this patient ended up making it outpatient and had a bronchoscopy with a right upper lobe nodule biopsied, which showed lung cancer. It was a lung adenocarcinoma. And there was concurrent liquid and tissue testing sent off, which is pretty much standard for I think everybody that practices at Yale and sees a patient with metastatic disease. And it showed an EGFR mutation in exon 19. It was an exon 19 deletion and had a co-mutation in this CTNNB1. And patient had no brain metastases on staging brain MRI. So this is the information that we had, when we were thinking about first-line treatment.
Right, so a lot has changed in the last couple of years, well, really the last year or so, when we think about first-line treatment of metastatic EGFR mutant lung cancer. So, Mike, I think you're going to take us through a couple of the data slides, and then we can talk about how, in practice, we actually select from these different regimens. So tell us about first-line treatment.
Yeah, so this is it's a really interesting and much updated space in 2025. And as you can see on the slide, these are the options that we have available to us in the first line in 2025. A couple of newer combination regimens, and then as you can see, number 3 is the standard of care that we've had for since 2018 or so. But the combination regimens are chemotherapy plus osimertinib. Osimertinib is a third-generation TKI, really effective alone. It has good brain penetration. It's well tolerated pretty much across the board. And then the other option now is amivantamab, which is an EGFR and MET bispecific antibody, and lazertinib in combination, which is also a very similar drug to osimertinib, a third-generation EGFR TKI. So now, we have these options, but how do we choose for an individual patient? I think the data that we saw come out, which really kind of solidified the combination approach in the first-line treatment, it came out in 2025. The first was presented in March, and this was the Mariposa study. And so the Mariposa study was looking at amivantamab and lazertinib in combination versus the standard of care osimertinib. So it was a good setup for a trial, looking at a good standard of care. In this trial, we initially saw some PFS results, but now we have the overall survival benefit. And it clearly looks better than monotherapy with osimertinib. Hazard ratio of 0.77 for overall survival. And, it looks like durable responses. So 61% of patients making it to 3 years out from initiating treatment. So that was one. And now we also have another trial that was just presented a couple weeks ago. We were in Barcelona for the World Conference of Lung Cancer. And this is the FLAURA2 regimen. We also saw PFS data in 2023, but this was the overall survival that everybody was waiting for. And this trial showed an OS benefit for OC plus chemotherapy versus osimertinib alone. And I think one thing that jumps out to me for this study is that the overall survival data just looked very similar to the other regimen. Even if you look at 3 years, 63% versus 51%, it's almost mirroring the Mariposa study. So this remains, another new option. This is where it gets tough. Now that we have these options, how do we select them? How do we sort of prioritize for individual patients? I think our group favors, with the data, especially the overall survival data that we see, the combination regimens up front are generally preferred. And I think it's very nuanced how we select those, mostly driven by individual patient factors and toxicity. So if a patient, chooses to avoid chemotherapy, they have a non-chemo option, an AMI laser. Or if they don't have good renal function, that could be an option as well. But, that's not without toxicity. So It's an individual discussion with patients. There's a lot of rash associated with AMI laser, a lot of swelling, paronychia, some fatigue. And so it can definitely be a long discussion. Yeah, you want to stop and talk about that patient?
I was just going to have a little bit of a discussion here because I think this is something, we see a lot of patients with metastatic EGFR mutant lung cancer in clinic, and we have several trials. I know we always try to think about putting these patients on trials because even though we've seen a survival benefit, we could still be doing better. These patients aren't cured with any of these regimens. So I was just going to actually ask Yeon to jump in. Mike, you laid it out really nicely that we have these different options. How do you think about this in practice? Are you thinking about using mutation type? Mike said that this patient had an uncommon, or it was one of those rare exon 19 deletions, co-mutations, brain metastases. How are you thinking about how to select patients?
Yeah, I think this is a tough case, especially because this patient had more of an atypical EGFR exon 19 deletion, and often these patients have a poor prognosis. Co-mutations in TP53 or other tumor suppressor genes, we've already seen that they have worse prognosis as well. So I do think that in the frontline setting, combination therapy is now the standard of care versus osimertinib. As far as which combination therapy, I tend to favor really the chemotherapy combination, mostly because right now amivantamab is still, the tolerance is a bit difficult. So Dr. Goldberg was talking about a trial we have, and one of the trials is amivantamab plus sub-Q amivantamab plus lazertinib. And for these patients, infusion reactions are less, but we are still seeing pretty significant skin toxicities, and they tend to wax and wane. They really have what's called a supportive care book bag, where they really need, doxycycline. Initially, for the first couple of months, they need anticoagulation. The rash is pretty significant. It's a whole body rash, where I'm seeing it in the chest, the legs, and also the scalp. They have a lot of pruritus in the scalp as well. So for me right now, I think I've been using a little bit more of the chemo combination with osimertinib, but I think AMI plus laser is also a very good combination. Maybe something to think about is they did, I think it was a poster presentation at World Lung, where they looked at resistance mechanisms. So amivantamab does target MET, so there is a less of a MET amplification seen in these patients who progress on AMI plus laser. So I think that the types of therapies that would be available as the next line do change with what combination you choose.
All right, very good. So I'm going to skip over a little bit just for the sake of time. So Mike, tell us what happened with this patient, and then we can talk about what happened next.
Yeah, so this patient had went on to a study that we had, amivantamab, which was subcutaneous, and lazertinib, and had a good response, a lot of cytoreduction, and had the predictable toxicities, so rash, fatigue, edema, ended up having a dose reduction in amivantamab, and remained on it, with good control for a couple of years, and ultimately had progression in liver and bone, so in a couple of different organ systems. So I'll just go through quickly the ways that we think about resistance in this disease, which is an evolving field. There's kind of buckets of resistance, and I think of oligoprogression as an opportunity to keep patients on their systemic treatment, which ideally has control in other places. And if they have progression in a finite number of places that are amenable to local therapy, to consider engaging radiation oncology and surgery. But there's other times where you have to change the systemic therapy, like if there's progression like this patient had in a couple of different organ systems. We definitely try to send sequencing, so blood and tissue, try to get a biopsy to see if we can identify a targetable molecular resistance mechanism. And I think that directs how we think about treatment then going forward. So there's some examples of targeted molecular resistance where we can add a MET inhibitor or add a BRAF inhibitor. And then there's, I think more often than not, there's no identifiable resistance mechanism identified. And those regimens, we have chemotherapy plus amivantamab, chemo plus osimertinib, and then one of the newer drugs, a TROP2 ADC, datopotamab deruxtecan.
So maybe I'll ask you, Tom, I get you in the discussion here. I think this is often when we turn to our radiation oncologists when we're seeing patients who are progressing on first-line therapy with EGFR mutations and other situations, of course. But how do you think about selecting these patients that might be good for this first category of oligoprogression? What is oligoprogression?
Yeah,
when you think
so
about it?
thanks for the question. I think from a radiation oncologist perspective, right, managing these patients with local therapy is an opportunity to, as Dr. Grant mentioned, to keep them on their currently working systemic therapy in other sites. So when I'm evaluating a patient for consideration of SBRT or local therapy in the context of oligoprogression, I'm looking for a limited number of sites. That number is up for debate, somewhere between 1 to 5, generally lower than that, typically 1 to 3, that are amenable to local therapy without undue toxicity. So we're looking at location and what general toxicities may be. So I don't want to subject patients to substantial toxicity when we may not be offering cure, but that's one consideration. Overall, how the patient's doing, what we expect their performance status and prognosis to be. And those are some of the general considerations, but I think it does offer a data-driven option for patients to remain on their systemic therapy.
Awesome. Okay. So I think your mic's not on.
We lost it.
So thank you. I think maybe for the sake of time, we're going to move on to the second case. I think, Mike, you. Oh, yes. Okay.
So, this is tough because, as amazing as the EGFR discovery has been, and it's 4 years for the EGFR receptor, 20 years for mutations discovered in the metastatic setting. I know I've been doing this for 25 years. I don't think I've question is, one, are we pretty definitive that if someone can tolerate it, I would agree, they should get one of the newer regimens? I'd love to know what Dr. Vogel thinks, because he always tells us what he thinks. The second question I have is these TROP2. Why does TROP2 work? Do we know that TROP2 is upregulated? This is just the beginning of the TROP2 revolution. There's TROP2 with every one of those things you can't pronounce at the end. There are like 10 of them. So I'd love just a thought from the panel. And Dr. Vogel, I did give you do you want to tell us what you do? And are you still practicing? Sure. We need you.
Thank you. So I don't know what to do either. And I have a question. When you give chemotherapy in osimertinib, are you giving the pemetrexate until progression? Because that was the way the protocol was written. I asked Pasiani, who presented it first, hey, do you think you really need to give the pemetrexate? And he said, I don't know.
Right, that's the way the trial was designed, was that it was given at the time
continuously.
in maintenance.
So chemotherapy is much more acceptable if it's term limited. And it makes sense that most of the benefit is early on, but I don't know.
Yeah, I think the median number of cycles of pemetrexed was, I think, 8 or 9
Right,
in that
that's
trial.
right.
So patients did get maintenance, but as you know, when you treat patients at some points, they get tired or have other side effects. So
I think
not
the median
everybody went on.
duration was 8 months.
Any comments on that? Are you giving maintenance when you decide to give the fluoride regimen?
Yeah, I think there's some patients who don't mind coming in. I typically would go with, just because that's what they did on protocol for the study, or at least start it. And then if you're up against the wall and you have to stop because of the renal function or another reason. But I agree, I don't think we know the answer to that.
So what I do is when I want to treat oligometastases, I'm most care about the quality of the patient's life on the current therapy. So when I had a patient doing well on osimertinib with 1 or 2 progressive lesions in lung or liver or adrenal, sure, maybe we can prolong his time on OC because it's a nice drug. If the patient is scratching all the time, I want to change the therapy, not go chase metastases unless they hurt the patient. If the patient's in pain, sure, we'll treat the painful metastases.
I think it's such a great point. I think we're very used to tolerable first-line therapy for EGFR, so it's easier to justify doing that when it can be more difficult. It makes it harder. Yeah. For some patients, I agree. Yeah.
Dr. Grant, it doesn't always work. So sometimes you don't get a response. It's unusual, but we've all seen it. Would you switch right away if you were doing OC or OC Flora 2 for a month or two, the patient's progressing? Would you switch right away to the other regimen?
Yeah, I would. And I think one of the things that will be a tool going forward, hopefully, is monitoring ctDNA and potentially pivoting even if the patient is not clearly progressing, but maybe has a suboptimal response, doesn't have a good partial response, then that might be a reason to switch. And, to your point, I've also had a patient that really struggled with OC and then ended up going, switching after some mild progression and tolerating amivantamab amazing. So, it can be, there's more options in the later line now, which helps exactly, what you were mentioning.
And Roy, just to reply to your question about the ADCs, there are several ADCs that look really promising in EGFR mutant lung cancer. This is data for Dato-DXd, which is now approved for previously treated patients. And you can see many of these patients are responding and benefiting, and the median progression-free survival is 6 months. But I agree, it's probably just the beginning of this TROP2, but other directed ADCs in EGFR lung cancer.
Yeah, I agree. It really speaks to the fact that we need to do as many clinical trials in this space as possible, because it's good. You get the diagnosis of EGFR mutant lung cancer. Everyone's very happy you found an actionable mutation. But I've had someone out 11 years. And not with osimertinib. It hasn't been around that long, or just about. But with gefitinib. But I think this is one of those things where we see the light at the end of the tunnel. It's just a very long tunnel, and we have a lot of work to do. That's why we need the phase 1, Sia.
So we have another case, but I'm worried we're a little low on time. Shall we try to do it quickly?
Who wants another lung case? You all stayed?
Oh, Henry wants one.
Okay. Can you do it in 10 minutes?
Sure, we could probably do it in 5. What do you think?
This is a good panel we got here. Okay, 10 minutes and then we'll close.
Okay, this is good because we can get Tom more in the
one
discussion
extra
on this
CME
side.
credit for everyone that stays. Now, not all of you I see care about CME credits, but some of you do. So for one extra mock point, okay.
So Dr. Hayman's going to tell us about his case. Go ahead.
All right, perfect. And I'll try to go a little more quickly in the interest of time. So this is a 65-year-old female, former smoker, 40-pack year smoking history, history of diabetes mellitus, hypertension, presented with a cough. Turned out to have imaging that was consistent with locally advanced lung cancer. What do I mean by that? Right, we can see a cross-sectional image here of PET-CT with subcarinal hilar lymphadenopathy that's FTG avid, and a right lower lobe lung mass that is also avid, encroaching on the right main stem bronchus at that point. Workup with bronchoscopy and EBUS biopsy. EBUS biopsy showed the right lower lobe lung mass was a lung adenocarcinoma, PD-L1 of 70%, and the molecular testing showed that there was a KRAS G12C mutation found. Specifically, nodal sampling revealed level 10R and 7 lymph nodes were positive, and there were no distant metastases seen on PET or brain MRI. So this is an evolving space over the last several years. There's some data that we'll talk about in a minute that were updated at ASCO 2025. But there are a number of options now in both the resectable and unresectable space for locally advanced non-small cell lung cancer. In the resectable space, right, you could consider upfront surgery followed by adjuvant chemotherapy coupled with immunotherapies, or definitive chemoradiation followed by consolidative durvalumab. Additionally, neoadjuvant chemo-IO followed by surgery can also be considered in this space. In patients that are clearly unresectable, both from a medical perspective or from an anatomic perspective, then the standard of care remains definitive chemoradiation followed by consolidative PD-1 axis therapy, as we'll discuss in a moment. And so this is data that were updated at ASCO 2025. This is the Checkmate 816 trial. This randomized patients with stage 1B through 3A non-small cell lung cancer to 3 cycles of neoadjuvant chemotherapy followed by surgery versus a combination of chemotherapy plus nivolumab followed by 3 cycles, 3 cycles followed by surgery. The update at ASCO this year presented 5-year overall survival, which showed a meaningful improvement of 10% in overall survival to 65%. From 55% with the addition of nivolumab in the neoadjuvant setting, and a significant improvement, obviously, in path-CR rates to 24% with the addition of immune checkpoint inhibition in this space. And just briefly, the subgroup analysis here tended to show the benefit for nivo plus chemo was mostly in PD-L1 positive patients, tended to be a little bit stronger in the more locally advanced stage 3A patients.
Pretty amazing, though, that 10% improvement in 5-year OS with just the 3 cycles, neoadjuvant, nothing adjuvant. Just to highlight that. Okay, then tell us about Pacific, and then we could talk about how we think about how we choose for these patients.
Yeah, so this is, we're all familiar with Pacific regimen, but this was a randomized trial initially presented, I believe, published in 2017 in New England Journal of Medicine and updated here in the JCO. This is a trial that took only locally advanced patients, so unresectable locally advanced patients, and compared in the placebo arm chemoradiation followed by placebo to chemoradiation followed by adjuvant durvalumab, and showed significant improvements in both overall and progression-free survival with the addition of adjuvant PD-L1 axis therapy.
All right, thank you. So this is, if you come to our tumor board, we will commonly be debating these types of patients because there's several different options, as you nicely highlighted. Maybe I'll turn to Soyeon and ask how you think about selecting from these different treatment regimens, how you take into account PD-L1, mutation status. This patient has a KRAS G12C mutation. I think you might have a trial for this patient. Tell us your thoughts.
So as Dr. Goldberg mentioned, we tend to discuss these cases in tumor board. And unfortunately, a surgeon isn't here today. But I think the first question is this case resectable or not? And do we want to consider neoadjuvant therapy? I particularly enjoyed actually the breast section because they seem to actually be a lot ahead of us in terms of neoadjuvant therapy and what consists of PAT-CR, how do we get to PAT-CR. But overall, it seems to be the goal is to try to get to PAT-CR. And the New England Journal paper for Checkmate 816 was very impressive because for patients who achieve PAT-CR, their 5-year overall survival was 95%, which in our case now, we don't give adjuvant IO, or I at least don't give adjuvant IO for patients who achieve PAT-CR. So the first question is, are they resectable? And if they are resectable, do we want to give neoadjuvant therapy? I would say a majority of patients, I favor giving neoadjuvant therapy, whether that's targeted therapy with EGFR-based therapies through a trial, or whether that's chemo EGFR therapy that's off-label, but we could consider that. And then we also have a trial where they're looking at KRAS G12C inhibitors given prior to surgery, and I think that's also a great option. For this patient had a high PD-L1 of 70% and KRAS G12C, and these patients tend to be more immunogenic compared to other subtypes, so I think consideration of neoadjuvant chemoimmunotherapy would be something favorable for this patient. As far as other characteristics like single versus multi-station disease, I think that's also a question for the surgeons. And then in the next couple of slides, I have a few slides on NeoAdora that I'm happy to talk about as well.
Let's do 1 minute on NeoAdora, and then
Awesome.
we can wrap up.
So this would be something that's more targeted in a way where this was presented in ASCO, so it's looking at patients who are randomized neoadjuvantly, so they would get OC plus chemotherapy versus OC monotherapy, and then placebo plus double platinum chemotherapy. Patients underwent surgery after neoadjuvant therapy, and then the primary endpoint was major pathologic response. And as far as MPR, with the addition of osimertinib, that's given as a monotherapy or in combination with platinum chemo double therapy, there was an improvement in major pathologic response. Not too much differences in the subgroups. And if we could move forward a couple slides, there was nodal downstaging. And on the left, it does show that patients who received chemotherapy did have deeper responses, as shown in the waterfall plot. Patients with major pathologic response had a better event-free survival. And then at World Lung, they actually mentioned, how do we find these patients who might have a better response or prognosis? And they present this as very interesting Personalis Next MRD assay. It's being used in multiple tumor types in breast and also in lung cancer as well right now in the trial setting. So it's an ultra-sensitive tumor-informed MRD assay. And all they need is essentially an FFPE sample. And they do whole genome sequencing on this. And it's a very specific type of circulating tumor DNA. And what they found was that patients who actually had a clearance of their MRD at baseline versus pre-surgical, they tended to have be associated with major pathologic response. So the bigger question is, how do we get patients to pathologic CR? I think in the prior breast panel, they talked about there was like this certain switch therapies you could consider if they have a positive assay, biomarker assay, and I think that's potentially a direction that we can go to. So biomarkers, looking for patients who may respond better to neoadjuvant therapy versus not, I think is the next biggest question for us.
Thank you. And Tom, you want to wrap up the case? Tell us what happened.
Yeah, so this patient did end up getting neoadjuvant chemo IO followed by surgery. They had a major pathologic response or path CR and ended up doing very well with this treatment. Yep.
Amazing. All right. Any last questions or comments? All right. Thank you all so much to the panelists. Thanks.